Okay. Now moving on to the neuroanatomy of the language functions. Currently, due to availability of lots of radiological findings, it has been found that the neural networks for language are widespread in many parts of both the hemispheres. So, language centers are usually classically thought to be located around the perisylvian areas of the dominant hemisphere, which are perfused by middle cerebral artery. See, we can see here, this is the sylvian fissure, okay? And around this is what we call a perisylvian area. This is where we consider that the language areas are present. Here, this is the Broca's area in the inferior frontal gyrus. This is the frontal lobe. This is the parietal lobe. This is the occipital lobe, and this is the temporal lobe. So this is the frontal gyrus, inferior frontal gyrus, Broca's area. Then this is the association auditory area. This is the Vernix area, which is the superior temporal gyrus. And these red fibers, these are the arcuate fasciculus, which connects Vernix area to the Broca's area. Okay. So the cortical areas generally involved in language are left posterior inferior frontal cortex. As I said, that is the Broca's area, which is also called as anterior pre-Rolandic, posterior superior temporal cortex, which is also called as posterior area or post-Rolandic, and left precentral gyrus of insula. So insula is, if you open up the frontal and the temporal part, like inside this, the sylvian fissure, that is what we call as an insula, and the precentral gyrus, that means out here. So this area is involved in motor planning of speech. And the red thing that we see, the fibers, these are the arcuate fasciculus, which connects the Vernix area to Broca's area. Okay. Now, this perisylvian area is supplied by MCA, that is middle cerebral artery. So usually the infarct of middle cerebral artery of the left hemisphere has been found to have a lot of cases of aphasia. We can see here in this area, the superior part of the middle cerebral artery supplies the anterior portion, as I described it earlier, the Broca's area, the motor area, and the inferior part. The inferior part of the middle cerebral artery supplies to the posterior part, that is the post-Rolandic area or the superior temporal gyrus. So usually when patients come with left hemisphere MCA infarct, they are more found to have a language issue, aphasia. So now I would just, there are a lot of scales available for assessment of aphasia, but I would just do a certain pointers which we can use as bedside assessment of aphasia to get an idea of what exactly the patient is having. And I will also give you the names for all these scales that are available, which will give you a definitive diagnosis whether the patient is having aphasia or not. So to start with bedside assessment, these are the 6 things that we should look for when we are assessing a speech or language function of that patient. First of all, it is the spontaneous speech. So in spontaneous speech, again, the patient might be on an automatic level or at an emotional level. If it is at an emotional level, then we wouldn't have a lot of words to say. So in spontaneous speech, then we would say, if it is at only at emotional level, the patient would be non-fluent or using no words at all. And when we are at an automatic level, at that time the patient would be fluent, but only enough, not at a normal speed, not a normal tone, and he wouldn't have any, uh, he will have problems with fluency, cadence, and rhythm. So, what we should look out, and when we are assessing spontaneous speech of the higher, like better level of communication of a patient, like a volitional level, at that level we should look for whether the patient is having any neologisms or any paraphasias. Like if they are trying to, there might be certain words that they are not able to say, so they are just using a different word for it or using a different sound for it. Like for a watch they might call blotch, or for a spoon, pass me the spoon, so he would just say pass me tool. So these are all the words that, yeah, okay, when they are using it, then we can just make a note of that. Okay, this is what we found in his spontaneous speech. Other than that, sometimes we also find that patients are not being more direct. They are trying to be evasive when they are trying to make a spontaneous speech. Like if you ask, so how did the day go? Yeah, 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 yeah. That's what they say. So they are trying to avoid. Yeah, 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 it's fine. No, no, I'm all good. That's how they answer. So that is when you find out, okay, this is circumlocution. They're trying to be evasive. They are not using more words. Their vocabulary is reduced. Next, we see for the comprehension of the patient. Now, comprehension can be tested by just, asking patients to do simple following, making them follow simple commands, like asking them to shut your eyes, open your mouth, stick your tongue out. All these are like very simple commands, very easy to follow. So, but at the same time, if the patient is not able to follow such commands, we should not jump to say, okay, the comprehension part is absent. Because sometimes during some apraxias, like buccofacial apraxia, which I'll cover later, they might not follow your simple verbal command. They might not do it in front of you, but the comprehension may be intact. So at such times, you could just ask something very funny, or something for which they could give us a non-verbal answer, or we could just ask them, could you move your head up and down and answer in yes or no? You could ask, where are you? Are you in a cab? Are you on some other planet? Did the sun rise up today? And if you could ask something funny, they would laugh at it and they would make a joke of you. So if even if we observe that they are laughing at you, that means their comprehension is intact. But otherwise, if you tell them to move your finger up or head down or something of that sort, like stick your tongue out, they wouldn't do it. So that could be due to different reasons. So that is what we need to be careful about. Again, while assessing comprehension, if the patient is able to do a simple thing, like you understood, the patient is understanding something, he's saying yes and no. So the simple basic level of comprehension is intact. But it could be such that if you give them a multi-step command or a complex situation or a bit complex question, they might goof up in that. So you have to step it gradually and see how they answer it. And also we need to check the level of arousal, alertness at that point of time, because if level of arousal is reduced, then you can't really comment of comprehension, because that will be biased. Next is when we move on to repetition. So in repetition, we give them certain words or certain phrases, so and ask the patient to repeat it after us. It can also check, retention, small short-term memory and everything. But also while repetition, we will again watch whether they are, changing sounds or not able to, or changing sounds or changing words altogether while repeating it. So the common sounds that we use to see are repertoire, like repeat per, ter, ka, or we can also ask like them to repeat phrases like no, ifs and buts, something of that sort. Also, repetition could be impaired in some kind of aphasia, like Broca's, and it won't be impaired in others. But still, there will be certain part or certain thing that will be overlapping. Now, the naming. Naming assessment is very easy. You ask the patient, you put an object in front of them which is of daily use known to patient, and you could just ask them, "Ki, could you just tell me what it is?" Like you could put like in a hospital setup, you could just put a glass of water in front of them and ask, "Okay, what is this? Can you tell me?" Or a key or something like a pen or a pencil. And at that time, you could observe for the response, for the time taken for response, whether whether there is any hesitancy present at that point of time. Other than that, in naming, again, you can ask for a patient to name, a certain, you can just tell them to make a list of words and you could just give them a subject. Like you could tell them to say, name animals or name flowers, and you can just check how many in a minute. You put timing to it. Name as many animals as you can, and your time starts now. You'll be given a minute, and then you can see how much naming and all they do it. Other than that, you can ask, like, if the patient is not talking and you want to see whether the patient can recognize. So at that time you can just say, okay, I'm going to say the word and you are to point out where is this object in the room. So you could point out, you could say curtains, and the patient is asked to point at curtains. So this is another way of checking naming. Writing writing again, the patient, usually patient with aphasia may have difficulty in writing as well, but patients who are having dysarthria or verbal apraxia, they might be not having any issues in writing. So for to check for writing also, you can give them some. You can just give them a pencil paper if the patient is able to write, and you could just see, okay, how he's doing. If you could, you can tell that you can give them regular words. Again, while checking for writing and spontaneous speech and repetition, we should be careful that the words and the phrases that we give are not at the automatic level, which are not used daily but known to the patient, so that we get appropriate answers. Usually, even while writing, if we ask the patient to write their own name, they find it very easy to write. But if you give them a different phrase, or if you give them a different line or words, they find it difficult to write. And also you can see the writing will be different. While writing also, the spelling error will be different. Like as I said, in neologisms, they, as in spontaneous speech, when the patient forms new words, similarly in writing, the patient might just scribble something. He might start writing his name in a right manner and then just end up scribbling something else. So this is all what we need to observe. Again, even in the reading, same as writing, the patient might find it difficult to read, but some patients, they find it difficult even to express it, and it could be due to different involvements. So reading, uh, the I like I could say, they can't read it out aloud, but they might be able to copy it down. So it could be because of different areas that are involved. So you need to check all aspects of reading accordingly. Now moving on to scales of for assessment of aphasia. So these are some scales that I found which are usually used for assessment of aphasia, which are very comprehensive and could be used to keep a check on how the patient is doing. The first three are quite comprehensive scales: Boston Diagnostic Aphasic Examination Scale, Neurosensory Center Comprehensive Examination for Aphasia, Western Aphasia Battery. The last three are more of like in functional assessment scales of aphasia, wherein they check the communication which is required for activities of daily living, and if the patient is improving on those, then it is more helpful for the patient. So these are functional scales: functional assessment of communication scale, communicative activities of daily living, and functional communication profile. Moving on to classification of aphasia. Classification of aphasia has been attempted in different ways, like anatomically, pathophysiologically, and a lot of things. What I read, more of them was like you could differentiate like expressive and receptive aphasia, fluent and non-fluent aphasia, central and paracentral aphasia. So I have gone with the Vernix Cashman model, that is the Boston classification, which recognizes 8 aphasic syndromes and which they have divided under fluent and non-fluent aphasia. So 8 syndromes are as Broca's, Wernicke's, conduction, global, transcortical motor, transcortical sensory, transcortical mixed, and ernomic. This is the classification of aphasia. Hello. Yeah, this is the classification of aphasia. So under non-fluent aphasia, they have classified Broca's and transcortical motor aphasia as well as global aphasia. In non-fluent, the speech production is always effortful. There is quite slurring of speech. The syntax error is there. Patient only use nouns. They use minimum words. Patient is aware of their flaws and they are quite frustrated with it. So language comprehension, again in these areas, we find very mixed pictures. Like you can't really point out. Sometimes even in Broca's aphasia, certain like a simple command is comprehended, but a simple multi-step command is not. So this classification is right here in front of you, but clinical picture can be quite different. So language comprehension is relatively intact in Broca's aphasia, but the repetition of words or phrases is quite poor. So usually they would just use around 2 or maximum 10 words in a minute for talking. Transcortical motor aphasia, they have strong repetition skills, may have difficulty spontaneously answering questions. Trans in the difference between Broca's and transcortical motor aphasia is the repetition part, wherein in transcortical motor aphasia, patient is easily able to repeat all the words that are given to them or phrases, not very easily, but compared to Broca's aphasia, they are able to do it easily. Then, in again non-fluent aphasia, language comprehension is impaired in global aphasia. Now, in global aphasia, there is severe expressive and receptive language impairment, may be able to communicate using facial expression, intonation, and gestures. Fluent aphasia, oh, sorry, fluent person is able to produce connected speech, sentences, structure is relatively intact but lacks meaning. So fluent aphasia, I will give a nice example where we also used to call it as verbal diarrhea, wherein you ask patient, how are you? Oh yeah, we had a very nice time. And then he would just talk about something which is totally irrelevant to the question or setup or surrounding where we are. So language comprehension when is totally impaired. That is the time when we call it as Wernicke's aphasia. The repetition of words and phrases is poor. The patient will be able to speak, but not what we want them, what we tell them to repeat or anything. They will just speak anything that comes to their mouth. Then transcortical sensory aphasia. Repetition is good, but may repeat questions rather than answering them. That is, they keep on repeating what we ask them, that we also call as echolalia. They just keep on, if we ask, what is the time? So they will just say, time, yeah, time. That's what we find in transcortical sensory aphasia. Then language and comprehension is relatively intact in conduction aphasias and anomic aphasias. Conduction aphasia, in this, usually the patient finds it difficult uh, to express themselves and also the worst part is they are aware about it. So as these patients are quite frustrated because they are aware that they are aware of their lacking, and they are also aware that they want to say something but they end up saying something else altogether. Like if one of my patients wanted to ask, okay, how are you doing, how's your mother, and he ended up asking, you are how, father? And then he corrected himself saying, oh, how are you, father, mother? So because of the situation, I could make it out that what he meant, but it is quite difficult for a stranger or in a normal communication for that person to keep talking or to even make communication. Anomic aphasia, the repetition of words and phrases is good. Word finding difficulty is always present. In anomic aphasia, the patient will be able to repeat what we tell them, but will find it very, very hard to describe anything that is kept in front of them. If you ask, if you place a key in front of them and ask them to name it, they'll say a lot of things about key. They'll describe it about its metal, about its make. They'll tell, okay, it's car. It is used to open car. It is used to open a home. It is used to open, but they wouldn't say that it is key. So that's about classification of aphasias. Now, in this table, I have just given you the areas involved or the eight aphasias. I think we've tried to cover them, and also the areas involved and what do we find as we studied how to assess aphasia, the spontaneous speech part, the comprehension part, the repetition, naming, reading, comprehension, and writing. Reading comprehension and writing. So in Wernicke's aphasia, usually the area of infarct is posterior superior temporal gyrus. Spontaneous speech is fluent, comprehension is very poor, repetition is very poor, naming is poor, writing and reading is also poor. Broca's aphasia, it is third or inferior posterior frontal gyrus, where spontaneous speech is non-fluent but comprehension is good. Repetition is poor but maybe better than spontaneous speech. Naming is poor, reading comprehension is good, but writing is again poor. Global aphasia, global aphasia, third frontal convolution and posterior superior temporal gyrus, non-fluent speech, comprehension poor, repetition poor, naming poor, reading, writing, everything poor. Conduction aphasia. Conduction aphasia is when parietal operculum or posterior superior temporal gyrus area is under infarct. The spontaneous speech is it could be, you could call it fluent. At times it is fluent, and comprehension is good. The repetition is very poor. Naming is poor. Reading could be good. They could read out aloud, but it requires them to trace the fingers. Those are all the treatment techniques, and the writing is poor. Again, in anomic aphasia, the angular gyrus is the area of infarction. The spontaneous speech is fluent, comprehension is good, repetition is good, naming is very, very poor, and reading and writing comprehension could be good or could be poor. The transcortical motor aphasias, these are the areas of infarction, supplementary motor areas. Transcortical motor or sensory aphasias are usually found when the infarct is at the internal capsule, depending on the anterior or posterior limb of the internal capsule. It could be motor or sensory. The classic feature of transcortical motor aphasia is the repetition is better. It is good even in motor and sensory as compared to Broca's or Wernicke's area. So that is how you differentiate transcortical from Broca's or Wernicke's. Naming is poor, reading and writing. Reading is good, but writing is again poor. Okay. Pure word deafness. Okay, this is due to Hexyl gyrus connection. This area, the Hexyl gyrus, is present right below the temporal PST, superior temporal gyrus. Again, in this, the spontaneous speech is fluent, comprehension is poor, repetition is poor, as it says, pure word deafness. That is, the patient cannot process the auditory symbols. The comprehension is very poor. Naming is good, reading is good, and writing is good.